Welcome, 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 everybody. Grab your lunch. There's a lot of seats down here up in front. Really appreciate you coming in. From cases from the community, investigators discuss the optimal clinical care of patients with HER2-positive GYN cancers. I'm Dave O'Malley, and I'll be moderating today. This is our faculty. These are just two of the smartest people I know, and just such an honor to be sharing this stage. Dr. Kathleen N Moore, Dr. Alessandro Santin. You'll be hearing from them throughout this meeting. Here's our relative disclosures. And here's the commercial support for today. Research to practice, CME planning committee staff and reviewers have no COIs to disclose. This program will contain discussion of non-approved uses of agents and regimens. Please refer to the official prescribing information for each product for approved indications. Working with RTP and Dr. Love, the entire team is really amazing what they put together. And so Dr. Love interviewed 3 gynecologists, during which time they posed cases and queries on a number of key clinical issues. Video excerpts from those interviews will be featured throughout the program this afternoon, and we'll introduce them as we go over with the videos. Dr. Love will. This is where we're headed today. Dr. Santin is going to start us off to identify strategies to identify patients with HER2-positive disease. I'll discuss the available data and practical application of HER2-targeted therapies. And Dr. Moore will finish with identification and management of adverse events. We're all friends. We will start to refer to each other by first name rather than the formal Dr. Moore and Dr. Santin. No disrespect. Just we're friends and known each other for 20 years. On that, Dr. Santin, let's start us off.
Thank you, David. So let me start with a little bit of background information here. The human epidermal growth factor type 2 receptor, HER2-neu, encoded by the CRB2 gene, is a transmembrane receptor that include an extracellular ligand binding domain, that is the target of the antibody that we're going to discuss today, a membrane spanning region, and an intracellular tyrosine kinase domain. HER2-neu work as a preferred partner for heterodimerization for any other EGFR receptor, so HER1, HER3, and doing so plays a very important or crucial role in the signaling, the HER2 signaling, that is responsible for regulating cell growth as well as differentiation. The problem in cancer is that when a tumor overexpresses HER2-neu, most of the time because of CRB2 amplification, the tyrosine kinase is constantly activated. And this regulates the pathway, maintaining it active all the time. And as I'm showing you here, let me see that. These pathways are the AKT, mTOR, PIK pathway, as well as, again, the RAS, RAF, MEK, and ER pathway. So with now HER2-neu being a validated target also in gynecologic oncology, it's important to understand the incidence of HER2-neu expression in terms of, again, amplification and mutation in our malignancy. So let me start with uterine cancer. What I'm showing you here is the molecular classification published in 2013 by the TCGA, and this is only to show you that HER2-neu amplification is not really common in polyultramutated or MSI high or even copy number low endometrial cancer, but is relatively common, 27% in copy number high serous-like. And in another paper from my own group published on PNAS about 6 months before the TCGA, we were able again to confirm that 44% amplification in uterine serous carcinoma. What about ovarian cancer? In ovarian cancer, CRB2 amplification is a rare event. This is again Nature paper from TCGA, 100 of patients, less than 5% were demonstrating CRB2 amplification. And in cervical cancer is similar to ovarian, as you can see here. CRB2 amplification is a rare event, about 4%, but significantly about 6% of all cervical cancer, they harbor mutation in the CRB2 gene. So are there any clinical or molecular characteristics that are associated with gynecological cancer, the overexpression HER2 that are peculiar? And the answer is absolutely. Over 30 years ago, Andy Birchuk demonstrated that overexpression of HER2 in ovarian cancer was a poor prognostic factor. Over 20 years ago, my group demonstrated racial differences in the overexpression of HER2, and also that in USC, overexpression was a poor prognostic factor. And more recently, Britt Erickson looked to 169 stage 1 USC tested for HER2. She demonstrated 26% HER2 positivity, and she followed this patient for 50 months. And during these 50 months, 25% demonstrate recurrence. When she looked to the overexpression, she found that 50% of the patient with HER2 amplification overexpression recur versus 16% of, again, the HER2 negative. This is once again to demonstrate that HER2 is a prognostic of prognostic important, and is precisely the reason why these patients, stage 1, are also included, even if they were COP, in NRG GYN 026 study that is currently ongoing. Are there molecular characteristics that are peculiar of gynecological cancer? And the answer is again yes. This is my own paper published in PNAS on uterine serous. And again, majority of these tumors were MSI stable, TMB low, cold tumor, minimal infiltration of lymphocyte. But one of the characteristics is that about 25% have PIK3CA mutation. The lipid kinase that is downstream to HER2 that can maintain the pathway constantly activated. And the interesting thing here is that when we look to 17 primary cell line, 7 with CRB amplification versus 10 without, we found that almost 60 of these tumors have this PIK3CA mutation. Why is that important? Is because if you're treating with trastuzumab, single agent trastuzumab, this tumor, the PIK3CA mutation, they're absolutely resistant to trastuzumab preclinical in vitro. Instead, if there be amplification, the tumor does not harbor the PIK3CA mutation, you may be able to reach an IC50 that is again achievable in the human plasma, and this patient respond. Now, we are moving from unconjugated naked antibodies such as trastuzumab to ADC. So the question is, are these mutations also affecting the sensitivity to the ADC? And the answer, as you can see here, is no, as demonstrated by Dr. English when she was a fellow in my lab about 10 years ago. As you can see here, the ADC is dramatically more powerful because of the presence of the toxic payload when compared to the naked antibody in vitro, as well as in vivo. These ADC are able to cure all the animal versus only 40% of trastuzumab. What about ovarian cancer? This is a study also done by my lab looking to the expression of HER2 using 2 antibodies in 100 of USC and ovarian cancer. We look to the intracellular domain expression of HER2, and this is, by the way, is the recept test that you're asking your pathologist to run all the time that you want to know if your patient has HER2 overexpression. But we also look to the extracellular domain with another antibody. And the amazing thing is that in USC, the concordance was very high. Only 8% were showing discordance between extracellular expression and intracellular expression. But in ovarian cancer, this discordance was 42%. That means that the extracellular domain was shed, most likely because of metalloproteinase and cathepsin production of ovarian cancer, but this could potentially explain why GOG 160, right, single-agent trastuzumab in ovarian cancer was a negative study. How can we integrate HER2 testing using immunohistochemistry and FISH? So since the publication of our IIT, this randomized phase 2 study in advanced recurrent uterine serous carcinoma overexpressing HER2, and again, with the publication of the overall survival data 2 years later, NCCN guideline has been revised and now recommend the use of trastuzumab in combination with chemotherapy, carboplatin and paclitaxel, in advanced as well as a recurrent patient with HER2 overexpression. But the question is, what is the optimal testing to identify this patient? This is a very important question because solid tumor from different organs have unique characteristics in terms of HER2 protein expression and gene amplification. And that is precisely why the American Society of Clinical Oncology and the American College of Pathologists, they have, again, develop scoring criteria that are specific for breast cancer or gastric cancer. But currently, we don't have a universally accepted algorithm for uterine serous carcinoma. Here, I'm showing you the picture of Dr. Natalia Busa. She was the chief pathologist in our IIT trial with USC and Trastuzumab. She looked 200 of sample as a core lab facility at Yale. And what she found, looking to the 100 of USC, was there were important differences between breast as well as gastric cancer. Namely, as you can see here, major heterogeneity in the expression of HER2-neu, even in 3+ positive USC. These are area of neoplastic gland, as you can see, completely negative, adjacent to 3+ positive HER2-neu. And this was a characteristic over 53% of the 3+ positive USC. 75% of this tumor, they lack apical staining, typical of gastric, not breast. So major differences that brought Natalia to develop this algorithm that is now accepted by the American College of Pathologists, and that is nothing else than the 207 breast cancer algorithm, so 30% positivity, keeping in consideration what I just told you, the heterogeneity of the tumor that is major in USC, as well as, again, the lack of apical staining. Now, I already told you, we are beginning to move from the single agent Trastuzumab to ADC, such as in particular T-DXd. Why? Because the ADC are order of magnitude more powerful than the naked antibody. And that is because in addition to the activity, the DCC, as well as the decrease in the dimerization of the HER2 receptor that is typical of the naked antibody, now we are adding the toxic payload that get internalized through the surface because of the receptor. And these ADCs, they also are endowed with bystander effect. So they are much more powerful, as we have seen in the DESTINY trial. And by the way, I remind you that in the DESTINY trial, we use the gastric criteria to identify, again, the 3+ and 2+ positive uterine, ovarian, or cervical cancer patient. But even more important, the DESTINY trial has clearly demonstrated that there is a new category of targetable patient, namely HER2-neu 2+, FISH negative patient, that we did not treat it in our IIT, but where we have seen clear activity in the DESTINY trial. What is the optimal source of the testing? I have 2 minutes left. So clinician should request HER2-neu testing in tumor tissue biopsy or resection specimen, even better, prior to the initiation of the targeted treatment. When you're looking to HER2-neu, you have to start with immunohistochemistry. Always start with immunohistochemistry. And if the tumor is 2+, that is when you're going to follow up with the FISH. You don't need to validate the 1+ or the 3+ positive. Very important point, pathology should identify and mark the areas with the strongest intensity of HER2-neu expression in the immunohistochemistry specimen and run the FISH on that specific area. When I moved to Yale, now over 17 years ago, the percentage of positive in USC was 17%. Only using this strategy, our pathologists, same pathology, went from 17 to 34% positivity. The prevalence of HER2-neu status may be discordant, and this is important, between primary and metastatic site, usually in about 15 to 20% of the patient, but in the recurrent setting, this can be even higher. And NCCN guidelines, they recommend now Trastuzumab, because of the IIT study that I show you, in advanced recurrent patient, but in gynecological cancer patient with recurrent tumor that have 2+ or 3+ expression, the indication is now Trastuzumab Deruxtecan. So finally, my last slide, are there any other methodology to identify patients that you could be targetable with Trastuzumab or T-DXd? And the answer is yes. We can use next generation sequencing, the commercially available platform, Caris, Foundation, Tempus, you name it. But what I need to emphasize is that the accuracy at this time point is still uncertain. In gastric cancer and breast cancer, we know that the concordance is good, but even in this tumor where there is more experience, this methodology, the next generation sequencing, is less sensitive in low-level gene amplification. So I'm talking about the 2.1, 2.2 FISH positive, okay? In endometrial cancer, again, we go from 50% concordance to 100% in some other paper, and Yale, again, experienced 139 USC, tested at Foundation Medicine and with the gold standard FISH, again, was 81%, the concordance. So the clinical HER2 testing remained the gold standard and should not be abandoned. Okay, I'm done.
Beautiful.
I did it. In 10 minutes. Okay.
Alessandro said, you gave me 10 minutes. Said, I need 15. I said, you get 12. Said, I can't do it. I said, you can do it. So, video cases and questions for the faculty. And I see Lindsay Wilmot here, right here. Lindsay, how you doing? 72-year-old status post-surgery, newly diagnosed metastatic HER2 positive, IHC2+. She followed your algorithm. She gets FISH, amplified, UPSC. Play the video.
Good afternoon, everyone. I'm Neil Love from Research to Practice, and to enhance this program, I met with 3 gynecologic oncologists, Drs. Kelly Schneider, Lindsay Wilmot, and Tom Morrissey, to present relevant cases and questions to the faculty, beginning with Dr. Wilmot, who has a patient with HER2-positive endometrial cancer whose status post-surgery to resect the primary tumor and intra-abdominal metastatic disease.
This is a 72-year-old who presented with postmenopausal bleeding, and sampling by her gynecologist was not feasible related to cervical stenosis. So because she was not accessible for biopsy, a decision was made to proceed to the operating room for more definitive surgical intervention. And at that time, she was identified to have evidence of metastatic disease with ovarian cysts that appeared very abnormal and an implant on the bladder. All of that disease was resected, and pathology did confirm uterine serous carcinoma that was metastatic to the ovary and bladder peritoneum. She had somatic testing performed, which revealed HER2 on her IHC. So then this was reflexed to C-ish, and she was noted to be amplified. The company that I utilize for my somatic testing, automatic reflexes, patients with 2+ IHC to C-ish. So that is their protocol. She then received 6 cycles of carboplatin, paclitaxel, and trastuzumab, and has now transitioned to trastuzumab maintenance and is without any evidence of disease on her imaging.
Any questions you'd like to hear discussed about this case?
So this particular patient is without evidence of disease on imaging. How long would you continue the trastuzumab maintenance? The other question that I have is, how do you monitor your patients who are on long-term trastuzumab in terms of potential treatment-related toxicities, including possible cardiac toxicities?
Dr. Santin, you know, you and Amanda led the IIT. We're going to talk about that data in a minute. But I just saw a patient the other day. She's had 5 years, similar regional disease. So how long do you continue the trastuzumab?
Difficult question to answer because we don't have prospective randomized data to tell us. But what I can tell you is that in the IIT, there was no limit. So, you know, I kept patient on that study for 3, 5, 7 years on trastuzumab. Now, again, the trend in a situation like this, at least in my practice, is to keep them between 12 to 24 months, depending, of course, how tolerable is the trastuzumab. And we monitor by echocardiogram every 3 months the ejection fraction to be sure that they keep on tolerating well treatment.
Katie, how about you? We had a conversation. I mean, I think, you know, I'm kind of a forever person. Well, how about you?
We certainly, at our institution, we have people that were on the NCCN guideline therapy, and they've been on for several years. I do wonder about this. We were talking ahead of this because we actually had to look it up in NRG GY026, which is Britt Erickson's study. It's for a year. But there are many patients on that study with stage 1 and more adjuvant treatment for their endometrial cancer. And so that may be appropriate. You know, if you have a stage 1 and you give a year of trastuzumab, you wouldn't want to treat that patient for 7 years. Versus a stage 4 recurrent tumor where they had previously been, I mean, quite frankly, terminal. Like, do you ever stop it? I just think we don't quite know. I agree with Dr. Santin. In an adjuvant setting, I like the option to stop. And so I actually really like 026 if I don't have any evidence of disease, I don't want to overtreat. But I am hopeful this is a place where liquid biopsy may be able to help us, circulating tumor DNA, incorporation of that. We're just starting to see that data come out to really help us individualize therapies for patients, but we are not there yet.
And I think so. Early stage, I mean, on trial, we're going to do for a year, like we said, but in clinical practice, we have a lot of these patients who participate in that trial are coming up at 3, 5, 7, well, I guess 5 years now. So I think for our standpoint, beyond 5 or 7, the chance they're cured at that point has to be pretty high. And I'm having those conversations right now, and I think, looking to stop. But again, if a patient with persistent disease, do you continue?
I would continue.
Now, who are you testing, Katie, who are you testing the HER2 across all histologies, not just serous?
100% of all gynecologic cancers are getting tested for HER2 at my site right now.
But early stage?
Oh, early stage, we are only sending our, I wonder if my partners are here. We're only reflexing our serous tumors. Because that can't, NGS isn't covered for early stage. And so at our site, that's done reflexively in pathology HER2 testing rather than everything else which we send out. But we're not doing that necessarily for endometrioid and clear cells for stage 1.
Okay. Alessandro, I heard IHC everybody, FISH 2+, okay? Is that what you're doing in a metastatic recurrent patient for ovary?
Okay, so regarding the histology, let me tell you, I had the carcinosarcoma to what Katie said.
You're right.
So that is what we do at Yale, even if that's early stage, our pathology look to that. We know that about 16% of all carcinosarcoma, they may 3+ or 2+ FISH positive. So even if it's not a huge number, still we open opportunity of treatment that otherwise we would not consider. Ovarian cancer, recurrent setting, absolutely, yes, you have to test for HER2-neu. We now have the DESTINY trial data showing that in 2+ or 3+, you have a significant impact. So the answer is I test all these patients in the recurrent setting.
So I have bad news, guys. That was the easy questions. All right? Let's see the next cases.
The next 2 patients are also status post-surgery for HER2-positive uterine serous cancer, both with involvement of one lymph node, but with an additional important biomarker finding. First, the patient of Dr. Schneider, in which the tumor is also MMR deficient and P53 mutant, followed by a case of Dr. Morrissey, in which the patient had a BRCA2 somatic mutation.
77-year-old had a new diagnosis of UPSC. She had 14% depth of invasion. However, one of her lymph nodes was positive with 0.65 millimeters of involvement. Her tumor markers showed her to be MMR deficient, which was surprising. Her HER2 was 3+, and she was P53 mutated. For this patient that we are going to be recommending paclitaxel carboplatin, what would people in this situation recommend for maintenance? Would you recommend an IO per Ruby or GY018, or would you recommend Trastuzumab to target the HER2 receptor? Has anybody used both an IO and Trastuzumab in these patients that have 2 targetable receptors? And would it matter if they were 2+ or 3+?
This is a 65-year-old diagnosed with serous carcinoma of the endometrium, was taken for surgical treatment, robotic hysterectomy, pelvic sentinel lymph node mapping, omentectomy. And the final pathology was invasive serous carcinoma, endometrium, 4 out of 10 millimeter myometrium invasion, no adnexal cervical involvement, but did have 1 positive right pelvic sentinel lymph node. Tumor profiling, the patient also had a tumor mutation in BRCA2. The patient's germline testing was BRCA negative. So we looked to treat the patient with 6 cycles of Taxol, carboplatin, Trastuzumab, which he tolerated well, no significant side effects, complete clinical response, CT chest, abdomen, pelvis after 6 cycles with no measurable disease and a normal CA-125 at that point. Those patients are HER2 positive and BRCA2 positive. What would be a recommendation for further treatment? Would you no further treatment and observe? Would you opt for Trastuzumab maintenance times 1 year, or try to use the BRCA2 mutation to our advantage and use olaparib maintenance times 2 years? Or would you combine Trastuzumab plus olaparib together in this patient, as kind of both targets are open?
So, Katie, DMMR, P53 mutated, 3 plus. She has positive node. Are you going to go with IO or Trastuzumab?
What I will start by saying, as we're testing more universally, I think we'll get a more accurate sense of the co-presence of these molecular findings. But the likelihood of having HER2, 3 plus, and DMMR is really pretty low. So we're not going to see a lot of these kind of in the world. So if I did see this, I don't have phase 3 data really in either setting, but we do have B21, which was powered in an ITT population, but in the cohort of DMMR, the addition of pembrolizumab in this adjuvant setting, this is a resected node, not measurable disease setting, the benefit, even though it was a subset, looked pretty amazing. So I'm comparing a subset analysis of a phase 3 to the randomized phase 2 that you all read or led until we get data from 026, which is testing in adjuvant. So I think there's not a right answer to this. But personally, I would probably add Pembro here because she's likely going to be cured with that. And I would hold TDXD for the unlikely event that she recurs. That's what I would do.
Alessandro,
Final answer.
you showed survival data on the CCR paper. I mean, what are you going to do here?
Here I really agree with Kathy because I believe that, first of all, this is a rare animal, MMR deficient, P53 mutated, HER2-positive 3 plus. I saw very few of these patients, and I'm sequencing many of these patients. Having said that, I believe that the microsatellite instability here wins in my mind. So Pembro should be the first choice because, as Kathy said, he may be able to really cure this patient, activating the immune system. And as you know, immune checkpoint activity persists for months and years after the completion of treatment, unlike, again, other treatment that we may offer.
So Katie, now she's found, you send off NGS, she has somatic BRCA. Are you using Duo-O? And let's go with, now she's P53, let's keep her up, DMR. So you find a BRCA mutation at DMMR patient. Are you gonna add a PARP inhibitor to the IO?
No.
Okay, what happens if she's PMMR?
Well, as I said yesterday, I had the pleasure of presenting some of the DUI data yesterday. We have to just say it's not FDA approved. So we're talking about something, well, everything we've talked about this far has been off-label. So it's all off-label, yeah. Right? So why am I bothered? So I would definitely consider PARP in this setting. If she were mismatch repair proficient in BRCA, I would absolutely be considering a PARP inhibitor. I do think we have to be a little careful when we're talking about somatic BRCA in BRCA, in endometrial cancer to look at the biallelic versus monoallelic loss, because you could just have a call depending on who your vendor is, and it's really not going to mean anything. So I would look at that pretty carefully, especially if I was deciding between HER2 targeting and PARP. But you have phase 3 data. I talked about the biomarkers yesterday. Looks to be a pretty even distribution of added PFS benefit over immunotherapy and compared to standard of care, which is no maintenance. So I would definitely consider olaparib here. I would also be looking to put her on GY026 though. I mean, 026 is open for HER2 3 plus adjuvant. So I would probably talk to her about the trial as a priority.
And I think, hopefully we'll have that enrolled completely. And I may have misspoke. I said Duo, I meant Duo-E. Alessandro, we have a question from the audience. And if you have a patient who's amplified, do you have to, should you check also IHC? Is there any reason to?
Yes, I would do that because as I've shown in one of my slides, there could be discordance between the intracellular domain expression and the extracellular domain expression. And therefore, if you look to the amplification, and this is a tumor that, let's say, you do the immunohistochemistry, and you don't find protein expression, right? It's unlikely that not having surface expression is going to respond to a targeted agent such as Trastuzumab or TDXD. In that case, I could consider, because I have the study open, afatinib, that is a pan-CRB inhibitor that blocks the intracellular domain of the HER2-neu, that is most likely the reason why the tyrosine kinase is active.
Interesting. All I can say is I'm glad I was moderating and not being asked those questions. Great session. We're going to move on here, and I'm going to talk about some of the available data and practical applications as we're going to go through this more with regards to clinical data to supplement the previous presentation. So this was originally JCO. It was investigator-initiated trial, also intent to treat. Investigator-initiated trial, co-led by Dr. Santin and Amanda Nichols-Fader with multiple institutions around the country. And what we found was a clear benefit with a hazard ratio of 0.44 in the entire population with the primary analysis of progression-free survival. But when we looked at the subgroups, these were not powered, the benefit really seemed to be those patients who are in primary therapy versus those on the right recurrent. So you see clear benefit. A lot of the questions we got with regards to this trial was, well, it wasn't blinded, you didn't have BICR, right? So we said, well, yeah, that is true. So we looked 2 years later, which was then published in CCR, and we now showed survival advantage. So we saw a survival advantage in phase 2. You see clear difference in those curves, and where we're looking now is a hazard ratio of 0.58. So over 40% advantage and clear flattening of the curves, leading to the belief that we are curing some of these patients. And where is the benefit? The benefit continued to be maintained in those in primary therapy, the upper Kaplan-Meier curve on the right, versus those in recurrent. So this is where that really changed the guidelines, as you heard Alessandro say. We also have, trastuzumab is an old drug. We've now been 25 plus years utilizing it in breast cancer. But the next generations of the ADCs and such, we have new opportunities. So one of those is pertuzumab plus trastuzumab. And when we looked at the I always say this wrong, tapper. We saw activity, modest activity in these groups of patients with HER2 and HER3 alterations. Most of those being amplifications described there. As we move down, and you've heard us refer now multiple times to GY026 being led by Britt Erickson, but co-PI Dr. Fader and translational PI Dr. Santin, okay? We see this 3-arm trial utilizing those 2 drugs, okay? Pertuzumab and trastuzumab. The control arm here is just carboplatin and paclitaxel. The middle arm being that just with trastuzumab, and then with the sub-Q combination formulation and maintenance for 1 year, and we're hoping that this trial will be completed shortly. Katie alluded to, this is enrolling all patients from stage 1 up to stage 4, measurable and non-measurable, and we included carcinosarcoma on an amendment here in addition to serous. But we also have looking at here into tucatinib, which is a HER2-directed TKI. We studied this in multiple cohorts combined with trastuzumab. And this is the paper we published in metastatic biliary tract. Yes, I do have a publication in metastatic biliary tract, which showed that we had actually a 47% response rate, which we would expect less than 10%, no greater than 15% of objective response rate here. So again, looking at using dual HER2, anti-HER2 therapy, but in this case a TKI plus trastuzumab. And then published just here last month was our Nature of Medicine in the metastatic breast cancer with the breast cancer cohort. 31 patients, modest numbers, But yet, the reason it was really accepted in Nature of Medicine was because of the translational work that we've done. This is a representative slide, and you can kind of drill down this with time permits, looking at local and central IHC. We have NGS, but both from the tumor as well as from the blood, as well as looking at then amplification. So again, you see differences in here, and you saw in the wonderful presentation by Alessandro with regards to the difference here in these patients. But how about you looked at TDM1? In this case, the NCI match trial looked at TDM1, which is again HER2-directed ADC with an anti-microtubulin payload. Modest benefit, you had to have HER2 amplification with copy number greater than 7, okay? And we only saw 2 patients respond to parotid, though we did have stable disease in half of the ovarian and uterine cancer patients. Again, small numbers, but showing that we have HER2-directed therapy. The status trial, which we alluded to in the carcinosarcoma just in the discussion a minute ago, again, this was our first really drop the mic that we had something here in TDXD in patients with uterine carcinosarcoma. You see almost all patients had regression disease if they were HER2 expression high in the lower left or next to it, HER2 low. And you see on the right, the swimmer's plot, that we have prolonged benefit in these patients. Well, then TDXD, leading to the agnostic approval was our 6 cohorts of solid tumors, and we've all seen this now, and Alessandro showed you in his presentation. But when it's first presented and led to the NCCN guidelines, it was 2 and 3 plus. And the data was presented as 2 and 3 plus, then all comers. It doesn't take much math to figure out that the 0 and 1s must have looked a lot like the 2 pluses. And so we saw that at last year's IGCS, when we see the difference here across expression levels of all of our GYN tumors presented at IGCS by Dr. Lee. Obviously, we have the 3 plus that is outliers, 85% in uterine, 75% in ovary, 64%. But let's take this with a grain of salt. 13 patients endometrial, 8 patients ovary, 11 patients cervix. Okay, so we're all thinking amazing. This needs to be confirmed in a larger trial if it's varied. Am I advocating by showing this slide that we should be treating TDXD in 0 expressors? No. But I do think it builds upon the Destiny breast cancer trials. This is Destiny Breast 04, looking at patients who had low expression. And you see here with this clear benefit versus physician's choice chemotherapy in those with low expression in metastatic breast cancer. On the left, PFS, on the right, OS. The update to this shows that this improvement persists with clear difference in those 2 curves, both in the hormone receptor positive in all patients. But this to me was the most interesting. This is Breast 06, Destiny Breast 06. This included ultra low and low. So low defined in breast cancer is 1 plus or 2 plus with negative FISH, or ultra low that IHC greater than 0, but less than 1 plus. Greater than 2 lines of therapy, again, TDXD versus physician's choice, and those physician choice are shown at the bottom, basically 2 different taxanes and capecitabine. And we see in the intent to treat was the low, so the primary analysis, I'm sorry, not intent to treat, the primary endpoint was those with lows. Clear difference with a hazard ratio of 0.62 and a change of about 5 months with your medians. When we looked at the BICR that is consistent in the intent to treat population, so that include the ultra low, but let's look at more closely at those ultra low. Much more modest. This was an exploratory analysis showing potentially benefit in those with ultra low and maybe some separation in the overall survival, but again, pre-specified exploratory analysis, a planned exploratory analysis. And why did I show that? Because really when we are moving forward in, for example, GOG 3112, the Destiny Ovarian 01 led by Joyce Liu, we're looking at the first line setting in TDXD plus Bev versus Bev in a maintenance strategy. And this is an ovarian cancer trial, as I said. This is allowing based on the gastric criteria, 3+, 2+, and 1+. Clear evidence that the lower expressions may benefit from TDXD, but we need to see how it compares in our patient population, especially when we talk about the limited numbers we have. This is not yet on clinicaltrials.gov, but we do have permission to share. This is being led by Dr. Macker. This is an endometrial cancer, and this is looking at can TDXD replace carboplatin paclitaxel in the first-line endometrial in proficient endometrial cancer patients. Because we're going against carboplatin paclitaxel, it only allows 3+ and 2+. 40%, which will be 3+, and 60% will be 2+. So this trial, as I said, is going to be going on to clinicaltrials.gov this next week or two. And what are other agents that we see? Well, BioNTech 323, we saw this presented by actually Dr. Moore at last year's SGO, where we see a response rate up to about 58% in a small number of patients, 59 actually, okay? Now, that also is a HER2-directed, also with a topo-1 inhibitor. And this has also led to a phase 3 trial, and now we have recurrent endometrial cancer after IO therapy, and it's going to be BNT323 versus physician's choice, in this case, doxorubicin paclitaxel. So all three of those trials are moving forward to confirm the Pan-Destiny 02 trial and the exciting preliminary results we see. And this is being led by my partner, Dr. Flor Backus. So we have the 3+ gastric criteria tumor agnostic accelerated approval as of April 5th of this past year. Clearly, the greatest benefit clearly may be overstated. It appears that the greatest benefit is much higher than the 3+. We need to further explore those lower expression, and we have multiple trials that are initiated to confirm these results. Oh, thank you. Let's look at some cases now.
The next case, presented by Dr. Wilmot, was a 38-year-old woman with cervical cancer that later on in treatment was found to be HER2-positive. Before that, she was treated with cisplatin and whole pelvic EBRT and brachytherapy, followed on progression by carboplatin, paclitaxel, bevacizumab, and pembrolizumab, followed on progression by tisotumab vedotin.
She actually was on that therapy for a very long time, for 26 cycles, but then developed some flank pain, and imaging confirmed that she had a new pelvic sidewall lesion leading to ureteral obstruction and associated hydronephrosis. Biopsy confirmed recurrence of her squamous cell carcinoma, and somatic testing of that biopsy did reveal that there was HER2 upregulation with 3+ IHC staining. So the patient has now started Trastuzumab Deruxtecan. She actually did incredibly well at the tisotumab. In terms of toxicity, she did not have any issues with ocular toxicity. She did the eye drops. She was very compliant.
Any questions about this case?
If this patient had had testing that included HER2 testing prior to initiation of the tisotumab vedotin, would you have preferentially selected TDXD prior to TV? How would you sequence those things?
So she starts TV, okay, and she does fine, but she's now thinking, okay, if I would have had HER2 testing at 3+, what would I have done? Katie, we've talked a lot about this. Why don't you start us off?
We don't know. That's the answer. But this is, these sequencing questions are sort of just the next level as these medications, well, now TDXD is accelerated approval, but as these confirmations happen, we really have a lot of work to do to figure out the optimization of the regimen. Where do they belong? Where does TDXD belong in a treatment algorithm for cervical cancer? Right now we have it sort of relegated to the recurrent second line and beyond status, but it may move up. Same thing with endometrial. You just heard it may be in the front line, same in ovary. Is it a platinum resistant opportunity? And I say that because depending on where it is, if you use it for a year and you don't progress on it, that tumor that grows back may have different mechanisms of resistance as compared to a tumor that progresses on Trastuzumab Deruxtecan, progresses on Trastuzumab or on Tisotumab vedotin. So I think this is absolutely the right question. I think about this in ovary with mirvetuximab and Renatibart, 2 folate receptor alpha targeting drugs. Does it matter which order I give them? I think it might, but I might be wrong. Here, does it matter which order I give them? Does a microtubule toxin lose efficacy if I use it after a camptothecin, or they're just so completely different that it doesn't matter? And I don't know the answer here, because I bet you in a 3+ TDXD will work better, but I don't know that but I'm going to guess. I bet it would work better. And if Tisotumab vedotin works just as well as it would in the other, and I give it after, okay, great. PFS1 plus PFS2 is long. But if the reverse is true, then the kind of stacking up of medicines in the recurrent setting, the sequencing may be important in terms of that longevity that I quilt together for OS. So I'm really interested in this question, as you can tell, because I've thought about it, but I don't know. I don't think any of us know. Do you know?
No.
Because he usually knows. That's why I'm genuinely asking.
At least I pretend I do.
He genuinely knows.
I think the anti-microtubule versus the topo-1, the topo-1 payloads is those are the questions we're trying to answer. That's why we're trying to design clinical trials which look at getting biopsies in previous treatment. Alessandro, I'm going to switch gears here a little bit. And in this case...
So you don't allow me to answer?
No, Katie's got such a good answer, there's no answer. But what I am going to do is switch gears with you, and I'm going to change it to a primary patient. A primary patient that you, I guess that doesn't work. So you start TDXD on the patient. She gets a CR. She's not primary, she's recurrent. She's a CR. She's starting to have some hematologic toxicity, but she's doing okay with it. Do you ever use, and this is a question from the audience, ctDNA to make decisions about abbreviating or continuing therapy in those patients? Or do you do that in a adjuvant setting at all?
The answer is that we are really starting, we have started very recently to use circulating tumor DNA as a way to monitor response in our patient. So again, it's too early for me to tell how effective, sensitive in my practice this strategy is going to be. But there is no doubt that I published in the past paper looking to circulating tumor DNA using raindrop digital PCR. That is a very effective way to quantitate the amount of DNA coming from the tumor, because you're going after a specific mutation that are circulating in the plasma, and for sure is a very sensitive approach, in particular when you know the mutation that you want to identify. So the answer is you may be able to monitor your patient in a very, let me say, sophisticated way. The answer is going to be, if the circulating tumor DNA is beginning to rise, but your CAT scan is still completely negative, are you going to stop treatment or not, right?
So I'm hearing something we're interested in, maybe not quite there. We never better design trials. Let's see the next cases.
The next two patients, presented by Drs. Schneider and Morrissey, are cases of HER2-positive metastatic ovarian cancer, and both were also folate receptor alpha positive, creating the option of either Trastuzumab Deruxtecan or mirvetuximab soravtansine.
Mirvetuximab is obviously more studied or better studied in our literature for ovarian cancer as opposed to TDXD. But her concern and my concern with talking with them is that she still has significant peripheral neuropathy. And in my experience, most of the patients with mirvetuximab have worsening peripheral neuropathy. So she strongly wanted to try TDXD. And my question in that standpoint is, has anybody else faced this? Is there a recommended next step? Should I have pushed the mirvetuximab? She is doing well on the TDXD. She's had 3 cycles. Her CA-125 has decreased to 23, and she's tolerating it beautifully.
A patient at that time was started on mirvetuximab, but kind of the 4th and 5th cycle started to get bloating again and had progressing disease after 2 cycles, and then was started on TXDX. And again, responded pretty well to that after the first cycle, noted to be feeling better, then developed some shortness of breath, developed some interstitial lung infiltrates. And again, we held treatment at that point, and patient's disease progressed at that point. And so the question is, would it be something that would be used earlier in the treatment sequence? When patients progress on these agents, is it due to resistance to the payload, or is it due to the target mechanism of action? And in terms of sequencing these things, does it make a difference?
So you have a patient fully receptor alpha positive. In this case was greater than 75%. So true positive, not my positive, which is my specialty pharmacist asked me how low is too low the other day. But you look at this and you say, okay, you have 2 positive biomarkers, Katie. So I know and from a data standpoint, you're involved in the development of MIRV from the very beginning to its approval. What do you think?
Again, this is really tough. And the overlap thus far that we think is about 12%, although as we test more, I think those point estimates are going to get a little bit more accurate. But HER2 2+, 3+, and folate high, the overlap there is about 12 to 14%. So you are going to see these patients, and we're going to have to figure out which medication to use. And this is, again, to my earlier point, if I'm in the platinum-resistant setting, I would want to use both. And if the sequencing matters, I'm going to want to put them in the right order. And at this point, we just don't have any data that tells us which one, if it matters at all. It may not matter. So we have phase 3 data with PFS and OS data with mirvetuximab, and we have an accelerated approval with TDXD. Does that matter? I don't know that it does. I did think the physician's discussion, the neuropathy matters. So if I have someone with neuropathy, I'm of course going to use TDXD first. I'm going to give her a break, and hopefully her neuropathy is going to get better, and then I'm going to try and bring in mirvetuximab at the next line of therapy. Sometimes patients just are like, heck no to the eye talk, all the eye things. It's, if you really counsel patients, every once in a while they're going to be like, no, thank you. And they're going to pick TDXD instead because they don't want to deal with the eye drops. So, it's sort of, at this point, it's shared decision-making with the patient about the pros and cons of each medication, pneumonitis and hematologic toxicity versus no hematologic toxicity, but ocular disorders and potentially neuropathy.
Well, you also have alopecia, so I think that's also in TDXD, but some of my patients are concerned. It's usually not complete, but it's a little bit more so. So, what, I can't disagree, especially in a lady with pre-existing neuropathy, right? But we do have survival advantage with Mirasol, and I think from that standpoint, now I'm hoping that one day we'll have survival advantage TDXD. So for me, I would have liked to see push a little bit more on the MIRV. So Alessandro, you guys have had a great experience with MIRV, TV. What's your experience on those that are commercially available, TV as well as MIRV, in some of the efficacy and tolerability that you're seeing?
We are talking still about this patient ovarian cancer or in general?
In general, what's some of your lessons learned with regards to the utilization of MIRV in these patients from a toxicity standpoint and efficacy?
Again, as Katie said, we have to really, you have to know your patient, right? See how she has tolerated the previous treatment when you get close to this decision. And at that time point, if you have the embarrassment, like here, to have 2 potential biomarkers and therefore 2 potential treatment, you're going to identify the one that has potentially more activity in terms of response rate and the right pattern of toxicity that, of course, the patient can tolerate. That would be, again, my choice in a situation where I have, again, two ADC potentially effective in that specific
And she's
patient.
high expression on both, so what a great problem to have,
Yep.
right? So and we're going to talk a lot more about the toxicities associated with these agents, but let's watch a couple more videos.
The next case, presented by Dr. Wilmot, is an 81-year-old woman with metastatic serous uterine cancer that brings up another issue often discussed and debated in breast cancer: the sequencing of antibody-drug conjugates in HER2-positive disease, in this case, second-line treatment of uterine cancer with either T-DXd or pembrolizumab lenvatinib in patients without prior immunotherapy. The HER2 status of Dr. Wilmot's patient was not known at the time because this was before the emergence of T-DXd, and the patient received pembrolizumab lenvatinib.
She did surprisingly well on that regimen. She really tolerated it very nicely, completed 2 years of pembrolizumab, and actually was without evidence of disease. And she elected on her own to discontinue her lenvatinib and then was lost to follow-up because she was feeling so well.
I see that she had disease recurrence and a fistula requiring surgery and was then found to be HER2 positive. What happened next?
After she recovered from that surgery, she started T-DXd. She's now received 7 cycles and has had tremendous improvement in her perineal pain, improvement in the size of this perineal mass, and reduced symptoms related to kind of fistula-related leakage. So she's feeling very, very well.
Any questions about this case?
I guess the biggest question here is that if we had, in terms of therapeutic options for this patient, when she was diagnosed with her recurrence in March of 2020, if her IHC had been perhaps 2 or 3 plus, what would have been the recommendation from our panel for therapy at that time? Would providers have opted to proceed with T-DXd? And then perhaps if she had progression or intolerance of therapy, then considered doing IO plus lenvatinib?
Any other questions for the faculty?
Probably the thing I personally am most interested in is if the panel can kind of foresee the opportunity for moving up this option to earlier lines of therapy. But I am curious if they feel that there may be some replacement of cytotoxic chemotherapy with T-DXd in patients who are HER2 upregulated.
So I think this is my favorite case, Lindsay. I get asked this question all the time. So I know what my answer is, but Alessandro, you have Len-Pem, and then you have, I forget what she's 2 or 3 plus. So let's say 3 plus. So Len-Pem versus T-DXd.
The question is, if I had known that, right?
If you had known that, now she's recurrent. Yeah.
In the recurrent setting, I would say they would start with T-DXd more than Lenvima Pembro in a patient like this. Keeping the Lenvima Pembro, of course, ready at the time of progression. Again, the response rate is very high in a tumor that overexpressed at 3+ level, HER2-neu. And again, she had an amazing response. Now we know to the Lenvima Pembro, but not all patients with a proficient endometrial cancer respond that well. So I would go with the targeted treatment upfront.
So Katie, do you think we're going to cure people in the recurrent metastatic setting with ADCs?
I think there is the potential for some patients. I hesitate when I'm talking with patients. I'm in phase 1, so I get patients who are referred to me with recurrent disease, and they'll ask me, how long am I going to be on this medicine? Am I going to do 6 cycles? I get that all the time. I'm like, we're going to use this as long as it's working, and then we're going to use something else. And you're going to be on something for most of the rest of your life. That's sort of how I counseled people, and I still say that. But I do hold out, to quote our patient yesterday, now a little bit of hope that we might be able to stop at some point in the setting of complete response. And I have had patients on a different, not TDXD, but a different medicine in clinical trials who were 3rd and 4th line endometrial and have had complete responses. And like one of them was 2 years in, complete response. And she's like, can I just take a break? And of course I checked ctDNA because I'm like, well, I'm gonna check everything. PET, CT, all negative. So I gave her a break and she's NED, just kind of living her life right now. And I'm just gonna keep a close eye on her. I don't know if she's cured, but how many times in my life have I been able to stop someone's therapy, platinum resistant, recurrent endometrial, recurrent cervix, and just give them a break with no disease? Not very often, and I'm doing it, I wouldn't say regularly, but I can think of the number of patients right now that are walking around seeing me every 3 months, and I've never had that before, this de-escalation option. So I'm cautiously optimistic. I think using them in the right patient early on, 3+ HER2 in a frontline, that's the other question you asked. Can I cure some of those patients? I bet you we do.
Yeah. I think in the maintenance setting, people say that's a lot of treatment, but in that maintenance setting, we have low volume disease and you have a targeted therapy. I think we're going to increase our chance of curative intent. I hope. I think we have a good chance. So the question is, as we treat these patients more and we see these long-term responders or patients we decide to stop for a multitude of problems, are we going to see their disease recur? At this point, I have seen those recur, though they can get a holiday. And I see that with cytotoxic chemotherapy or regular chemo. But lenvatinib pembro, if you look at the where those curves flatten out on LEAP 001, there are patients who are cured with lenvatinib pembro. And so for me, and I have several of those in my practice. So I'm going to go with what I think is a better curative intent, which is the IO therapy plus the pan-TKI. And they're going to be earlier on in their therapy, hopefully to tolerate it better. So I'm going to use lenvatinib pembro there and reserve my ADC. But again, we don't know the answer. So perfect segue, because of toxicities, Dr. Katie Moore is going to talk to us about identification and management of adverse events with TDXD. Thank you, Katie.
So I'm going to talk about adverse event management, which is something I'm particularly passionate about because these drugs work amazing. Across the board, antibody-drug conjugates have been pretty transformative for our patients. And so our ability to prevent and mitigate toxicities, whatever they are, early on and really prevent not just the severe toxicities, and I'm going to talk about that, but also just the nuisance toxicities that make our patients' lives less rewarding while they're experiencing benefit from these antibody-drug conjugates is also a really important goal. And we can see treatment-related side effects from these antibody-drug conjugates. It's kind of like immune therapy. They can affect, depending on the target and the payload and the linkers and the metabolism, you are seeing toxicities that really run the gamut of all of the organ systems, from the main ones we're going to talk about today, which are mucositis and interstitial lung disease, but we also have some that are causing some transaminitis. We have, fortunately, not many causing a lot of renal toxicity, certainly neuropathy you've already heard about, ocular you've heard about, and others. So really, it's almost like the slide that we used to use for immunotherapy with every organ is impacted. We're back to that with antibody-drug conjugates. If there's anything you take from my talk today, it should be really good review articles that you can download and take home and look at. And this is one of them, not surprising, from the amazing Dr. Hope Rugo from 2022. This is her overview of management of TDXD-related adverse events, and really these haven't been massively updated over the past 2 to 2.5 years. So I'd encourage you to take a look at this and give it to your office staff. But you can see down the right or the left-hand side of this slide the toxicities that we think about with TDXD or any of these Deruxtecan payloads. GI toxicities are very common. Neutropenia is common. You can see infusion-related reactions, and so that's an important thing to include in your counseling for a patient who's about to start one of these medications. They're not severe. They're not MSID across the street to the hospital, but they can be scary to have someone turn red and have an infusion-related reaction. As Dr. O'Malley said, there is some alopecia. It's not like paclitaxel, but they will notice hair thinning. And if you don't warn them about that, that can be very distressing. Fatigue is about what we normally see with chemotherapy. And kind of erroneously small, there is ILD pneumonitis, which is sort of the biggest thing that we worry about. So let's start with just the easy stuff, nausea and vomiting. Nausea for the camptothecin antibody drug conjugates is one of the most common side effects that we see. These medications are in general highly emetogenic. So if you think about paclitaxel and carboplatin, that's a moderately emetogenic regimen, so you're using usually 2 pre-medications. These TDXD, Deruxtecan payloads are highly emetogenic, and so you want to really bring all your pre-medication guns to the table to mitigate this toxicity right out of the gates, because it is quite common. This is the incidence, so 70% any grade nausea. Grade 3 is really uncommon because we're good at preventing it, but it happens about 7% of the time. Emesis, 45%. Grade 3, really uncommon. Again, we're good at mitigating this, but it's common. How do you prevent it? You know, our clinical pharmacists, I'm so lucky to have good clinical pharmacists, great clinical pharmacists, but this is really where you need to set your beacon builds up kind of right out of the gates with good prevention. So you want, beacon build. So pre-treatment, you want a 5-HT3 plus dexamethasone, and if that doesn't work, you're adding in your NK1 plus 5-HT3s, dex, and you can also use olanzapine here, kind of post-medication or post-infusion for patients that are really susceptible. That's pre-treatment. Days 2 through 4, you're using your daily dexamethasone with or without metoclopramide or a 5-HT3. And if someone's really still struggling there, you're kind of adding in your next level with the olanzapine. And then days 5 through 21, you can have some patients with delayed onset nausea. This is pretty uncommon. Usually if you're really aggressive up front with your pre-medications, my experience with this and similar agents is that patients actually do really pretty well, but there's always folks that are more sensitive to these medications and they're not lying when they call you and tell you they're still nauseated. And so you really have to ramp things up to keep this under control. And so the mitigation you can see out to the side for the delayed nausea. If you really have someone that's struggling, you do need to delay dosing until it's better, because if someone's coming in with grade 2 and kind of barely hanging on and you treat them again without breaking that cycle, you're just never going to help them get out of that hole. If they recover in less than 7 days with your mitigation, you can keep them on the same dose. But if it takes a long time to get them resolved, more than a week, you probably should bring them down a dose level. This is pretty uncommon that you have to modify, but some patients you do, and you should. Okay, so that's nausea and vomiting. Neutropenia. So neutropenia is the other very common class effect with these camptothecin payloads. We didn't see much of it with mirvetuximab, actually almost none. The reverse is true here with these, makes sense, they're topoisomerase 1 inhibitors. And so this is because it's principally driven by the payload. We're getting off-target, off-site toxicity with the hematologic toxicities. It is one of the more common grade 3 or higher adverse events that we see with antibody drug conjugates, and it just is cumulative. And so you'll see this sometimes happening like cycle 7 or 8, right out of the blue. You'll have someone finally present with an ANC that precludes treatment because of that cumulative impact of the drug. At the bottom in red, I'm just showing you the particular data about TDXD. So all grade neutropenia is 35 to 43%, and this comes from the breast cancer literature. So maybe a little higher depending on how heavily pretreated our patients are. So keep that in mind. I think we'll get better data on this with bigger studies. Grade 3 is about 20%. And so you can see here, if it's grade 3, you want to hold until it's down to grade 2, and then you can maintain your dose. If it's grade 4, you hold, obviously, until it's less than grade 2, and then you bring it down a dose level. And certainly if you have repetitive grade 3, I would also consider dose modification here as well. Also, I would consider prophylactic G. I think we forget this a little bit. A lot of our patients are older and they do meet the ASCO guidelines for prophylactic use of G-CSF, not reactive use of G-CSF. And so you can see a lot of our patients are over 65. They have poor performance status. A lot of them have poor nutritional status. They meet these criteria. So if you're not sort of incorporating this checkbox into your assessment of whether or not you should just be using G-CSF right out of the gates, I would encourage you to do so with several antibody-drug conjugates that are in development, where we are seeing sometimes even more significant neutropenia, just to keep patients safe while they are, again, hopefully responding to these very active medications. So strongly consider use or consideration of G-CSF in this setting. So moving on, where's my arrow? There we go. Infusion-related reactions, I just wanted to call this out again. They're pretty uncommon, and they're really generally mild, and they're addressed really by slowing the infusion rate. You can usually restart patients, and it's just your standard reactions to infusion reactions. It's nothing kind of fancy. I just really wanted to call it out so you put it in your counseling list when you're talking to a patient, so they're not caught off guard if it does happen. Decreased ejection fraction, this is something we really focus on with Trastuzumab. So you heard Dr. Santin say we're checking every 3 months the echoes, and we really do have to keep an eye out for reductions in ejection fraction with that medication. We're not seeing it a ton in TDXD, but there are guidelines around watching for it. So we do still have guidelines, because you can see about 4% of the time. So it's not anywhere near as common with Trastuzumab, but it can be seen, and there are guidelines here. I'm not going to read all of these to you. They're in, you'll have my slides, and you can see Dr. Rugo's review article, which is where I adapted this from. But you do have to keep an eye on it, but it's pretty infrequent. So I just want to spend the most of the last remaining of my time on ILD pneumonitis. Pneumonitis is a class effect of several antibody-drug conjugates, mainly Deruxtecans, but not exclusively. So we really just can't be complacent here. You have to be looking at the chest CTs. This is sort of what we're seeing. It's about 10 to 15%, all grades. The majority of it is grade 1 or 2. These are the 5 S's. This is another great Dr. Tarantino's paper, another one I would recommend you pull down. This is just related to how we assess and mitigate for pneumonitis. You look for it, past history, make sure you're not treating someone that has undiagnosed pneumonitis. That's actually more common than you probably think, especially if they've had prior IO. Making sure you're scanning the chest, even if they don't have disease in the chest. Multidisciplinary care. Holding treatment if there's a suspicion of ILD, even if it's not symptomatic. That's grade 1. Ground glass opacities, inflammatory changes, clinically correlate. They don't say, hey, this patient has pneumonitis on the CT scan. They say all these things. Mild inflammatory changes clinically correlate. Before I understood this, I'm like, how you doing? I feel great. I'm so happy. My tumors are shrinking. I feel great. Great. Keep treating. Nope. Got to hold. And you got to work it up, and you have to use steroids, low threshold to start steroids. So I'll just show you this. It's trickier than you think. And so this is complicated. I don't mean that to scare you, but if you look at a baseline CT scan, you're like, well, I would never treat someone that had baseline abnormalities. That's an absolute exclusion. This is a great presentation out of Dana-Farber by Dr. Abelman, where she went back and looked at patients with breast cancer in their very able medical oncology practice who were treated with TDXD on label. And they went back and they had radiologists re-review all of the pre-treatment scans. They were all reviewed by a very smart person just to see what they found. Because none of these patients had baseline ILD. 93% of them had some baseline abnormality. That's pretty striking. So do all of these patients need PFTs and a pulmonary consult before they go on study? That's probably overkill, but what's the balance? This is tricky. These are the things that they found. Ground glass opacities. They found, of course, cancer. They found obvious evidence of interstitial changes, atelectasis. Did any of this correlate with who developed pneumonitis? And the answer was no. So it's not just a ground glass opacity. It's really pretty tricky. And then when they looked back and they said, well, who did develop pneumonitis of this retrospective cohort? The physicians didn't call the grade 1, but they absolutely recognized the grade 2. When they looked back at rereads by blinded smart radiologists, you doubled the pickup of grade 1. So you look at the bottom, the treating physicians assessed grade 1 7% of the time, grade 2 4% of the time. When it was overread, your grade 1 ran up to 23%, but that same 4% for grade 2. And so how important is it for us to pick up these grade 1s? How much are we delaying unnecessarily versus when do we risk somebody getting symptomatic and potentially lethal ILD? This is really a challenge, and I just encourage you to not try to be your own pulmonologist. And I don't say that lightly. We have to collaborate. We have got to have really good pulmonologists and radiologists who will work with us and really help us figure out who needs to be held and referred and for whom are they having an allergy attack and they can keep treating. Multidisciplinary management is key, and you can look at this in Dr. Swain's paper, hold, assess with pulmonology, high-res CT scans, often PFTs are recommended, and then suggestions for steroids, definitely if they're grade 2, and sometimes for grade 1 to try and get these to clear. But it really does require direct communication with the pulmonary specialist, because if you just refer for someone that feels great and has a ground glass opacity, they're going to see your patient in 3 months. So it takes direct communication to get this moving forward. And then these are the summary guidelines. And again, I won't go through these in the interest of time, but you can see they're very well outlined here in this Swain paper. The key is to pay attention, have the courage to hold, because your patients will be mad at you because the drug is working and they're very happy about this, and you're going to hold for a fuzzy thing on their CT scan. It doesn't go over well, but you've got to hold and get it worked up and treat with steroids if necessary. Anything that's grade 2 or above requires permanent discontinuation. And with that, I think we're kind of running a little bit over, so I think I'm just gonna, maybe we can kind of talk about some of these controversial topics in the discussion. Okay.
Awesome. Great job. Thank you.
Yep.
So let's play video cases.
The next case, presented by Dr. Schneider, is a 61-year-old woman with metastatic HER2-positive uterine serous papillary carcinoma, treated initially with chemotherapy and trastuzumab, followed by maintenance trastuzumab, which then led to tumor progression. The patient was then treated with pembrolizumab lenvatinib, to which she responded, but then developed highly symptomatic progression and was then started on TDXD.
She was very symptomatic. She had liver metastases and was emaciated. She has now gained 20 pounds back, feels much better, and is back to working. She's now completed 8 cycles, and she is NED.
Any acute side effects like GI toxicity?
She did not. I prepped her because this was my first patient on TDXD, and I knew the possibility of significant nausea, which she did have this with her initial chemotherapy. A question for the experts: are there any other suggestions in terms of getting patients through this from a nausea perspective? I'm not really sure exactly what is the best regimen or most recommended to help with these. She has not had any shortness of breath. That is another question that I have not completely gotten answered. Is there anything recommended for screening from that standpoint? She's getting frequent imaging anyway to follow for progression of disease without any evidence of interstitial lung disease, and she has no symptoms. But is there anything that we need to be doing more aggressively to evaluate for the pulmonary toxicity that can be associated with the TDXD?
Any questions if she were to develop ILD, either grade 1, asymptomatic, or symptomatic?
So I've not had to encounter that yet with ours. Can we continue that if she develops grade 1? Is it something that we can treat through? Any recommendations for if it progresses to grade 2 or 3? One of my questions: how long can we generally tell patients that they're going to respond to this medication from an expectation?
So Alessandro, you heard Katie's kind of toxicity. Wonderful talk, Katie. So what are you guys doing with regards to imaging of your lungs? How often are you imaging? Are you only imaging with symptoms? What are you doing?
So my patient on TDXD, of course, are in the recurrent setting, and the gold standard in my practice is to repeat a CT scan usually every 10 to 12 weeks, so every 3 months. So that is why, and that includes always, of course, a CT chest. Doing that, I believe that, again, I have not yet encountered, in all honesty, too many interstitial lung disease in my practice, but we do that to be proactive because we know how serious it may be. So,
Katie, anything more to add to that? How are you guys? Same thing?
Well, most of our patients are treating on a clinical trial of a similar agent, and so they're getting scanned every other cycle for the first 6 months, and then they went to every 4 cycles after that, which made me a little bit uncomfortable. So I think every 2 to 3 cycles is fine. The rate of ILD decreases when you get to really like 6 to 8 months, and then by a year it's pretty level. So you're going to see it relatively early-ish because people tend to stay on for a long time. So we had a few bad outcomes, so we're pretty sensitive in my institution. I know you guys have had some as well. We are pretty much every other cycle until we're like 6 months in, and then we'll maybe go to every 3, and then we'll back off a little more.
But it's interesting. From the TDXD, from the looking at the experience in the onset, we actually are seeing about 5.5 months at the median. So you see that kind of continuum. So again, that cycle 7, cycle 8, when you've been lulled into, okay, they're doing fine, is where you really need to redo the education. I think every 2 to 3 cycles, 4 starts to make me a little nervous because now you're pushing at 12 months. So I really try to do it at 9 weeks, and I get a CT of the chest every time. As I said earlier today, I've looked at more CTs of the chest in the last year than I have in my previous 30 in my career. And very, very important. Now,
Can I say one thing to that? Because I agree with that. I will admit, I look at CTs with my patients all the time in the room. I show them their cancer and we show so I pull them out. But I wasn't looking at the CT of the chest if they were just being, in a clinical trial, they're like CT chest. If they didn't have disease and the report said there was no cancer, I wasn't ever pulling that up until a few years ago. And I would encourage you to look at that because you'll get a report that's like waxing and waning ground glass opacities since 2020, slightly worse. And you're like, whatever. But if you pull that up and you can see that ground glass opacity, like you'll sort of get a litmus for what needs to be referred, even if the report, sometimes these reports are like one line, no cancer, inflammatory change clinically correlate. Look at the CT. And then make a decision. So I kind of joke you don't want to be your own pulmonologist, and you should not be, but you do need some sense of looking at these inflammatory changes. Yeah.
I agree, and I think also we establish that relationship with the pulmonologist, the synergy you referred to, right? Mm-hmm. Is we send them a secure chat now, and they'll jump on the phone with us. Like, hey, and it's an opportunity to continue the education for all of us. Because it is tough to sometimes get these people into pulmonary. When they're in the hospital and they're that sick, it's easy, right? But when they're at home where you're seeing them, it can be more challenging. So I think with where we are, you did a wonderful job. These are moderate to highly immunogenic agents. We need to use 2 and 3 drug combinations. So let's move on for our last case and hear what Kelly has to say. Dr. Schneider.
The final case brings up an issue that's been known for many years, the potential cardiotoxicity of anti-HER2 treatment, where most of the data has focused on Trastuzumab. Dr. Schneider has a 62-year-old woman currently responding to TDXD after prior Trastuzumab therapy, where cardiac issues have been noted.
So you can see on her MRI, there is tumor eroding through the wall of her uterus to the perimetrium to the side wall on the left on this MRI, but the tumor was on both sides. It was worse on the right versus the left. I put an associated picture of the hydronephrosis. I also added in a picture from her PET scan showing the liver capsule involvement as well as the bulky disease in the pelvis, making her not a surgical candidate. At the time of her admission, they did an echo showing an ejection fraction of 41%. So we talked with cardio-oncology. They said to give them 4 weeks to adjust her antihypertensive regimen. We ordered a repeat echo, which 4 weeks later showed that her ejection fraction had improved to 50 to 55%. So they gave us the okay to start TDXD, but they did recommend an echo every 4 to 6 weeks. She's now completed 8 cycles. Her CA-125 is normalized. Her CT scan shows continued decrease in lymphadenopathy with no new disease and resolution of the lung disease. And her echo still remains normal.
Another amazing case. Any questions?
My question in this standpoint is, knowing that TDXD is targeting the HER2 receptor and we assume has some of the same toxicities as Trastuzumab, is it an option in a patient with reduced ejection fraction?
So tough one, right? This guy's Kelly here. She's so tough one. So it comes in, as a baseline, she got reduced ejection fraction. She's got recurrent disease. What do you think, Alessandro?
I must tell you that, you see, the majority of the literature in terms of trastuzumab toxicity does not come from the gynecologic oncology literature, come from the breast cancer literature. And you have to remember that. Because this patient, majority of breast cancer patients, they receive adriamycin, and only later they get trastuzumab.
And chest CT, and chest radiation.
I must tell you that I wrote a paper a few years ago, only really to look to the toxicity, the cardiotoxicity in our study. We follow again the 61 USC 3+ positive, right? Half of that they received 4 years. I can tell you at 92 years old that they were treated for 5 years with trastuzumab, checking ejection fraction every 3 months. They did not receive adriamycin before, and they did fantastic. So trastuzumab is a very benign drug, let me tell you, in our field, because our patients, they have not received a cardiotoxic agent, most of them, before. So in a situation like this, of course, with ejection fraction of 41, that with some, again, monitoring, goes back up to 50, 55, and no hesitation to recommend, again, the ADC targeted.
I think, again, the context of where we are. So let's move a little bit from cardiac. I mean, we've talked a ton about ILD. So for the audience, we're down to the last minute or so. What's your take-home points? I mean, you went through the 5 S's. Anything else you want to add? You kind of skipped over some controversial stuff. Anything else you want to add in closing?
Well, Kelly asked a question. I don't know if she's here. She asked a question in the prior about what if I had a grade 1 or grade 2 or grade 3, can I treat through it? And so the answer to that is no. Don't treat through it. No. Can you restart with a grade 1? I was going to show you in my slides, and you'll have my slides so you can see the reference. There's not a prospective study, but the breast cancer literature, they've had more time, and they have published and presented data on patients with grade 1 pneumonitis, which is asymptomatic. So they're not hypoxic, they're not coughing, you're just catching this on a CT, who did or didn't get steroids for clearance. What happens when they reintroduce the TDXD? And so we do have an emerging data set that shows that it is largely safe. Most of the patients restarted without even a dose modification and didn't recur with ILD, but a third did have recurrent ILD, which was treated with steroids. They had no deaths. They had no grade 3 or up because they were watching them, so closely. So for grade 1, that's resolved with collaboration with your pulmonologist and a patient who's benefiting. I do think you can restart, and we have done that several times because we're finding so much grade 1. In a grade 2, even if they were just coughing, there are currently no recommendations. You're going to see case reports, but there's no recommendations that is a safe thing to do, as painful as it is, because the drug works so well. If you restarted and they had a bad outcome, that would be a tremendous kind of liability for you and, of course, your patient. So I wouldn't comment on that. Grade 1, you can re-challenge. And there is
but beyond
support.
That, no.
Beyond that, no.
I want to thank all of you for joining us. It's the top of the hour. Dr. Santin, Dr. Moore, brilliant as always. Thank you for all of your questions. I'm sorry I could not get to all of them. We'll be here for a few minutes. And don't forget about tomorrow. Dr. Moore is back with another panel. Thank you very much, everybody.